History of present illness, you've got a 49-year-old male presented to Athens with chest pain. Initial EKG was normal. He proceeded to have V-Tac, V-Fib, cardiac arrest. He was accepted to Park West Medical Center through rapid access. What is rapid access?
Rapid access is a service created by Covenant to make it easy for outlying facilities to call and get patients transferred to any of the Covenant facilities. In other words, rapid access might accept a patient, or they'll get both doctors on the phone. They'll typically either two ER doctors, or sometimes they get a hold of me and then I interact with the ER doctor, the transferring facility. And then they, once I verbally have accepted the patient, they make arrangements to get ready for the patient coming to that facility. So rapid access is a Covenant service to referring doctors, referring facilities.
All right. Do you know whether you evaluated Mr. King in the emergency room?
From review of the records, I can go by what the ER doctor said. I was there. So.
All right. And appears as if you did an examination of Mr. King?
Yes.
All right. And what were the main findings from your examination that mattered to you in terms of you coming to an assessment and plan for him?
Well, mostly his history. I think there was EKG that showed ST segment elevation, suggesting MI. You know, the physical exam I documented was cursory because of the emergency nature of the presentation of the patient.
All right. If you could explain, since this is your area of expertise, and take a little time to explain to all of us, what does V-Tac and V-Fib mean?
These are unstable cardiac rhythm that characteristically, although there's an electrical signature that can be diagnosed V-Tac or V-Fib, typically it's myocardial standstill. Typically those rhythms do not promote organized cardiac contraction, and so it's these are ventricular tachycardia is associated with sudden cardiac death. I mean, that's what V-Tac, V-Fib is. You know, when you have go to Knoxville Airport, there's defibrillators on the wall where the device can be applied to the chest, and an algorithm can diagnose V-Tac or V-Fib and independently shock the patient back to normal rhythm.
And what's happening in the heart to produce a V-Tac or V-Fib?
In this case, it was intense ischemia. Ischemia is from a Greek word meaning lack of flow of blood.
And how does the lack of flow of blood produce the V-Tac or V-Fib?
Well, the heart is exquisitely sensitive to supply of oxygen. So lack of oxygen, and there's a sequence of electrolyte disturbance even at the cellular level that can make the cellular membrane unstable for electrical conduction and can set up for this type of arrhythmia. Arrhythmia meaning these abnormal heart rhythm.
And what is asystole?
Asystole is typically, when you look at a EKG, it's flatline.
How does that differ from V-Tac and V-Fib?
Well, as I said, the asystole is flatline. V-Tac or ventricular tachycardia is, I could draw it for you. Would that be useful, or it's versus V-Fib?
I think maybe help explain is if you look at a strip and you see a flat line on the strip, is that asystole?
That's considered asystole.
All right.
Where if you see kind of prolonged fine pattern of minute or smaller electrical depolarization, it's just kind of doing like this, that's ventricular fibrillation. Ventricular tachycardia is a bit more organized, but it's much more wider deflection of the EKG.
All right.
Rhythm strip.
And what is an acute anterior myocardial infarction, which was your assessment?
Myocardial infarction is where there's indicated permanent myocardial injury. That defines myocardial infarction, and acute anterior identifies what part of the heart we think is involved. We derive that from the pattern on electricity on the EKG. What we look for is ST segment elevation. ST segment, if trying to explain EKG, there's a certain portion of the EKG that is sensitive to electrolyte disturbance or lack of oxygen, and so if we see acute ST segment elevation in certain parts of the EKG, we can reasonably guess where the injury to the heart muscle is occurring.
I see. And I see your plan here was for an emergency heart catheterization. Is that correct?
Yes.
All right. Why don't we go to, if you go through one more page, let's go to your cardiac catheterization report. And what I'd like you to do is take your time and explain what you did for Mr. King, and also what was causing the MI, the myocardial infarction.
The myocardial infarction was caused by what I've documented, 100% occlusion of the mid-LAD, the left anterior descending artery. The artery, or the blood supply to the heart going over the front of the heart, is the left anterior descending artery. He had disease in other vessels, but clearly there was 100% occlusion of the mid-left anterior descending artery. And what I did was, we enter the circulation through a needle stick in the right femoral artery, the artery at the groin area where your pocket is, pant pocket, and we pass a catheter, like a straw, to the beginning of the artery, pass a guide wire through it after the patient's heparinized, and then place a balloon and stretch the occlusive plaque open. And then we place a stent. A stent is a metal scaffold mounted on a balloon that is pressed into the artery and acts like a scaffold holding it open. And then during the course of this, after I got the artery open, he was hypotensive, and so I elected to place a balloon pump, an intra-aortic balloon pump. Should I keep going, or
Yeah,
what that is, or
I'm going to break
that?
this. Yeah, I'm going to break this down to small bites after you finish. But go
Okay,
ahead, let's talk
I'll
about
stop.
that. Okay. First of all, because I'm just telling you, there's some things that most of us don't know. When you say 100% occlusion and you're talking about plaque, can you define what you mean by that?
No flow past a certain point.
And I try to use things that more common terms we understand, but is that like the tube being blocked off where the blood can't pass through it?
Yeah,
All right.
that's correct.
All right. Now, when you talk about doing this cath procedure, you did a good job explaining that it goes through the leg, but what I'd like you is give us a little bit more detail. You're there. When you say I'm passing a catheter, can you be a little bit more descriptive what we're talking about here?
Well, sure. After the patient is prepped and draped in a sterile manner, and we place gown and gloves and mask, and you feel for the pulse in the leg, or it's right at usually where the femoral head is, and enter the circulation with a needle stick, an 18 gauge needle, and then through that we pass a guide wire. Then we take the needle out, and then we place a hemostatic sheath, a sheath that allows passage of other catheters, but it doesn't let it bleed back. And over a guide wire, a specialized catheter that's pre-shaped is advanced to the ascending aorta. And then we proceed to, during the case, we heparinize the patient, and then we verify, adequacy of treatment, and then we meaning the cath lab personnel, then once we've identified the blocked artery, I request a guide wire, and then the guide wires pass through the complete blockage. Sometimes flow improves almost dramatically once you've opened up a small channel with the wire, and then over the wire that's down the LAD we place a balloon angioplasty, and we inflate the balloon for 20 seconds, 30 seconds, take it down, and then flow is restored.
Now, this is my ignorance because I'm a layman here. Why can't you just suck that clot out, like mucus or something else like that?
Certainly that is a treatment option. Certainly you can, there is a type of device called a pronto where we can, over a guide wire, suck clot out if there appears to be clot material, and certainly the process of acute MI does involve clotting at the plaque site. It's to decide on extraction catheter is really what it looks like angiographically. If you see just a block and you don't see other material in the artery that looks like it could be clot, then I'm going to reach for a balloon and a stent, because that has the greatest likelihood of getting that artery open and keeping it open.
How does the balloon do its job to restore blood flow?
Well, it stretches the plaque, it deforms the plaque, it's also causing localized injury to the vessel itself. And that's why we also, within this environment where you have clotting and coronary spasm as a result of clot, certainly the stent is very useful at treating the associated coronary spasm that occurs. To understand that better is to know that, like, when a clot is formed, chemicals are released from the clot to make the vessel constrict on top of an already occlusive fatty plaque.
It's like a double whammy.
Certainly.
All right.
Certainly, that's why the treatment strategies for years was using a clot buster, such as TPA. Research showed that if we can visually see the artery open, that has a better prognosis than doing straight up clot buster.
So you're,
or thrombolytic.
to deal with this double whammy, you're having to actually stretch this vessel as well because it's been constricted by virtue of the chemicals from the clot?
Partly, and also by the inflammation caused by the plaque itself, and the plaque itself is bulky. So, I mean, certainly if you cut your hand, you want to stop bleeding. And so our clotting mechanisms help constrict the cut vessels that are bleeding and stop the bleeding. So, but in the heart, you're cutting off flow to vital heart muscle, and so it's a pathological response to the fatty plaque that was pre-existing.
How did Mr. King's heart respond to the balloon technique that you used?
Well, we got the artery open, and at the time he demonstrated large anterior apical and anterolateral hypokinesis. Hypokinesis means it's not squeezing like it should. The estimated ejection fraction was 30%. To understand ejection fraction is to understand that the normal ejection fraction is between 50 to 70. So, so his ejection fraction was significantly reduced.
All right. Was there anything else that you needed to do in terms of the catheterization other than what you discussed about passing the balloon and restoring the blood flow?
Well, as I mentioned, there was seeing that he had large anterior-apical and anterolateral hypokinesis. We had got the artery open. There was reduced blood pressure. I made the decision to place a intra-aortic balloon pump.
Now, what happens to the clot after you have performed your balloon procedure?
Well, it certainly, it's in the milieu of heparin. Heparin has some thrombolytic feature to it. Certainly, clot can dislodge and go downstream. But the body's own clot dissolving processes kick in. Clearly, the goal is to get the artery open as fast as possible.
Now, when you say heparinize the patient, can you describe what you mean by that?
Heparin is an anti-clotting agent. That's a standard of care whenever we do both emergency and elective coronary intervention.
All right. Anything else significant about the catheterization? I'm going through your report here that you think's noteworthy.
No, I think this is, we also treated his, treated his low blood pressure with an intravenous drug that's used to support blood pressure, namely dopamine.
And again, these are lay words, but did you consider the procedure a success from your standpoint?
Yes.
All right. Now, if you go to the next page, this is a echocardiogram worksheet.
Yes.
Is any of this your handwriting on here?
Yes, this is my handwriting. Typically, I take notes on echoes that I read, and this is my handwriting.
All right. What is an echocardiogram?
An echocardiogram is a specialized ultrasound tool to look at cardiac function, valvular function, possible to look for collection of fluid around the heart, wall motion, and it's done by a specialized wand or tool that's placed on the chest, utilizing a water-soluble lubricant that helps transmit ultrasound into the body. And ultrasound is reflected back from the structures into the device, and it's the pictures that we interpret from.
Does this give you a insight into looking at the heart itself?
Exactly.
With imaging?
Exactly. It gives us, we can diagnose chamber sizes. My abbreviation here, left atrium was normal, mitral valve appeared normal. LVH means thickening of the heart muscle. There was distal septal and mild apical hypokinesis. And the ejection fractions seem to have improved significantly from the initial cardiac catheterization assessment.
Now, let's get your best medical opinion and judgment. Why is it you believe that the ejection fraction improved after the procedure?
Well, when we go in to do an acute MI and see that part of the heart isn't performing like it should, and we never know if we're looking at permanently injured or permanently dead muscle, or is it stunned? I mean, there are some biochemical protective mechanisms within the heart that the heart will respond by not working, that once it has flow restored, can go back to, can improve, can significantly improve.
And how is this finding encouraging to you based on what you have seen here in this echo?
So much of, I mean, one of the cornerstone precepts in cardiology is the ejection fraction. That is a big determinant of prognosis and outcomes. I mean, it doesn't guarantee outcomes, but it's a good prognostic marker.
If you go to the next page, there's some typed up information. Is that part of the echo? doctor?
Yeah, in other words, what happens is the echo tech presents us with this page. I make handwritten notes as I'm looking at the pictures, and then I look at my notes and then proceed to dictate.
All right. Let's go, I know you probably talked about this in the handwritten part, but let's just take a little bit of time to go through your findings. If you can just read the findings and explain to us what is significant from your findings.
Well, I'll go to my conclusion.
Sure.
There was mild hypokinesis of the distal septum and apex and infraapical wall.
All right. What does that mean, hypokinesis?
Well, kinesis means wall motion. So hypo means not squeezing as well as we'd hope it would. Hyperkinesis, although it's not on this document, would mean aggressive squeezing. But mild hypokinesis of the distal septum, apex, and infraapical wall. These are walls that reflect these walls are perfused by the left anterior descending artery. So it does show some residual injury evidenced by the hypokinesis. The ejection fraction was 50%. Left ventricular hypertrophy is a phenomenon of when a person has had, either it can be genetic or it can be untreated hypertension, can lead to thickening of the wall muscle. But it's, I'm just observing it on this echo. There was trivial mitral valve regurgitation, meaning that the heart has 4 valves that keep the flow of blood in a one-way direction through the heart. So one of the valves had a little bit of leak. You wouldn't necessarily be able to hear it on stethoscope, but the precision of the technology is able to detect it, and it's inconsequential. And then I wrote diastolic dysfunction. Diastolic dysfunction, to understand diastolic dysfunction is to understand that we break down the cycle of heart as there's a phase of systole where the heart is squeezing, and then there's a phase where the heart relaxes. And so you can get some diastolic dysfunction just with, it's a natural age response after age 50. But it also in some situations can cause heart failure, but diastolic dysfunction would not be unusual to find on anybody this age, and particularly in the setting of left ventricular hypertrophy.
How did these findings either meet or exceed your expectations from the surgery?
Primarily the recovery of near normal ejection fraction.
Why is that significant?
Because ejection fraction is an important prognosticator of outcome.
All right. Let's turn our attention now to prognosis, and I want you to focus now simply on the heart. We're going to get into the brain here in just a minute, but based on the findings here from your echocardiogram, from your surgery on Mr. King, what was your prognosis for his heart condition?
I think very good. Again, the ejection fraction is a cornerstone of prognosis. He did, on the heart cath, demonstrate other arteries with partial blockage. With compliant medical follow-up, his prognosis would have been reasonably very good.
The stent, the scaffolding, as you mentioned, what is the anticipated longevity of that appliance? Does it have to be, in other words, does it have to be changed? Can it stay? What is your expectation for that?
Once a stent is implanted, it's there for the life of the patient. We used a drug-eluting stent, and what that means is that the stent is coated with a chemical substance that prevents re-narrowing. In other words, in the old days with balloon angioplasty, there was a 40% chance of re-narrowing at 9 months. with modern stenting, the stents we use, the literature supports less than a 5% chance of clinical re-narrowing at 9 months. And if you get past that milestone, it's very unlikely that the stent will ever re-narrow. And it's not re-narrowing with fatty plaque, it's re-narrowing with scar tissue in response to the localized injury. So, from a cardiac point of view, I'd have to say I was optimistic.
And pleased with the results?
Yes.
All right. Now let's turn our attention to the neurological side of this. The next page is the neurological consultation. And did you ask for a neurological consultation for Mr. King?
The neurologist indicates that I did.
All right. Do you know what the purpose or why neurological consultation was asked for?
If you look at the natural history, what went on with somebody intubated out in the field, acute MI, sedated so they'll tolerate the ventilator, you're going to keep them sedated till the cardiac crisis is over. And then there's the neurologist accurately recorded that the intensivist used hypothermia protocol, meaning a cooling blanket. And then, so what gives us a clue that there might be a problem is when we stop the sedation. They're on the ventilator. We want to try to get them off the ventilator, and so we have to lighten or stop sedation so that they can cooperate with the process of getting off the ventilator. So because after sedation was terminated, the patient was not responding. And so a neurology consult was obtained.
All right. And what is to sum up in your own words, what is the result or the conclusion of that consultation?
I can read it.
Sure.
Severe anoxic brain injury with little or no cerebral activity.
All right, and doctor, what is severe anoxic brain injury?
Well, the heart, the brain, are organs very sensitive to lack of flow or flow cessation. So severe anoxic brain injury is reference to something that's caused injury to the brain on a global scale, as opposed to like a stroke where it was like a localized area, but it was a global injury. And it can present like it did here with Mr. King, or it can be sometimes some people, sometimes they recover, but oftentimes they don't.
I neglected to ask you this. Was Mr. King's consciousness revived at any point when he was at Park West?
As I said, the process of having somebody on a ventilator, sedation is stopped. So I think after a time where we know that the sedation is washed out, we start looking for signs of movement. And that's, so there wasn't, the neurologist documented here, all extremities are flaccid, meaning that nothing's moving. No arms or no legs are moving.
All right.
He did not respond to voice or nail bed pressure. And that's where we literally take our, like a hemostat or a tongue depressor and press it against the nail bed. That can be very painful when you're awake. So it's responding to pain. So those were the assessments that were made, partly by the intensivist and by me, and then finally we elected to get the neurology consult.
He has written here or dictated prognosis for recovery to consciousness is probably less than 10%. I imagine the jury probably knows what that means, but I want it on the record. From a medical standpoint, what does that mean to you?
Very poor. It's documented very, very poor. Well, just as it's documented, it's very poor prognosis for recovery.
All right. Let's go to the next page, doctor, which is, or a couple pages. I believe is your discharge note.
Yeah.
Dated May 26th. Does this summarize the care you provided and basically what happened with him?
Yes.
All right. What I would like you to do is just describe, as best you can recall, did you have any conversations with the family about Mr. King's prognosis, at least from a neurological standpoint?
Yes. Yes, we went over it with them. I'm sure we did. I know that there was a second neurologist that saw the patient, Dr. Loaiza, and I think they were aware that we felt like this was permanent terminal brain injury.
Okay.
Hence the decision for palliative care and placement on a sedative. And
All right. And what is palliative care?
palliative care is a specialized medical field now that helps with patients and families coming to terms with terminal illness. And it segues into, as an outpatient, hospice. Hospice is a specialized outpatient service that helps families and patients come to terms with their terminal illness, making comfort medications readily available, and so well, that's.
From a medical standpoint, did you believe that there was any reasonable need to keep Mr. King alive past this time in hope of a recovery?
No. I had two consultants, experts in the field, tell me that this is a terminal event.
And you rely on those consultants to come up with the best opinion as to whether the patient should be allowed to have palliative care?
Yeah, when the consultants have helped us identify, or if I've identified terminal illness, then I'll, outside of getting a neurology consult, will obtain consult from palliative care, and depending on the situation.
And I want you to understand, the reason I'm asking you this, some people look at this as like pulling the plug and have you done everything that you can do to try to make things better? That's where I'm coming from. From your standpoint medically, were you satisfied you all had done everything that you could possibly do to get a meaningful recovery for Mr. King?
In my opinion, yes.
All right. All right. Let's make those the next exhibit, your testimony, doctor. Doctor, is the left anterior descending artery, is that sometimes referred to as the widowmaker?
Yeah, it is in layman terms.
And to sum up, from a cardiac standpoint, your prognosis was good. Is that a fair statement? Okay.
Silent objection.
Let me rephrase. What I want you to do is just from a cardiac standpoint, was your prognosis, will you describe it for me? How if his brain function had been okay, if he had recovered consciousness, was your prognosis for his cardiac function still going to be good? That's what I'm trying to understand here is whether he would have been better.
That's a call.
Object to the form at what point in time?
Well, let's see if I can rephrase this. This is what I'm trying to say. Was your prognosis from a cardiac standpoint separate from the prognosis from a neurological standpoint? Do you understand what I'm saying, doctor?
That's a call.
You can answer.
Purely looking at the cardiac status, this was a successful coronary intervention.